The second thing.
Sorry.
Okay, the second thing, I will talk a little bit about the quality of surgery, which is something that we all are interested in. Now, if we look at these cases, this is a case that I did about 15 years ago. This is a fracture dislocation with a head split, and I operated on that patient, reduced it, used the place that we had at that time, and that's him after about a year, and that's his 1-year follow-up after this fracture. Now, after doing this fracture, I learned from the literature that I would have had the same result if I would have treated it conservatively. And there were lots of prospective, randomized trials, Holy Grail, which showed that internal fixation is no better than non-operative treatment of displaced 3-part or 4-part fractures. And the studies go back far and go on. Now, if you look at these studies a little bit more, closely, you see that in this Olerud study, for instance, the constant score for lock-in plates is 61 points. For non-operative treatment, it's 56 points. If you look at the EQ50, so a measure of quality of life, these patients are at 0.65. They start at over 8.5, and they end up in both groups at around 6.5. That means they lose about 20% in their score, both groups. So it is a dramatic thing to have a proximal humeral fracture. If you look at the complication rate of open reduction and internal fixation, it's alarming. So people operate with a lot of complications. We'll get back to why. If you go to the modern literature, they say the same thing. Non-operative treatment is as good as operative treatment. But I must tell you that, for instance, the often quoted Proffer study, I think, is something that is an example that randomized controlled trials can be unethical, stupid, and misleading. So if you look at that, you see that they had 3 groups. They had 160 cases, 160 fractures, older than 60 years, nothing more as information. And you were just said, you can operate on that, or you can treat it non-operatively. But if you operate on it, you can do whatever you want. You can do a prosthesis, or you can do an open reduction internal fixation. It was just operative versus non-operative. Now, the results were 30 points in the DASH score for conservative treatment, 31 for lock-in plate, and 26 for hemiarthroplasty. Those of you who use the DASH score, they know that the DASH score of 0 to 2 is really excellent. Up to about 10, it's good. Anything above 21 is poor. Now, all 3 groups have a DASH score of 30. So actually, randomized controlled trials have shown that both forms of treatment are equally miserable. They're not equally good, they're equally miserable. And we should be ashamed to adhere to the principles of these treatments. So what can you do about it? Rutherford said that all science is either physics or stamp collection, and these trials are certainly stamp collection of people who probably don't know a lot about stamps, but that's another thing. So we had one person who has worked a long time with us, who has really looked at that and tried to get some science into that, and reviewed a series of more than 300 fractures and analyzed them to see which ones were doing well and which ones were not doing well. And what he found out was that the so-called DTI, deltoid tuberosity index, which is this measure that you see here. I don't know, do you see that? I will probably not see that. Anyway, that you see here, it is measuring the outside of the shaft, right where the 2 cortices become parallel, the outside and the inside. And if this quotient is over 1.4, you have good bone quality. You can measure that with the Tingren index. You can measure that with the DEXA for the humeral head. You have good bone quality in the humeral head. That's one thing. But the more important thing is this DTI is very well correlated with pullout of screws and secondary dislocation. So the thing that was shown was that you have a good population for open reduction internal fixation, much more so if they have good bone quality than if they have a 3-part or a 4-part fracture. Now, on the basis of that, the department developed an algorithm for the management of proximal humeral fractures. And it is patient-specific and it is evidence-based. And I must tell you, it is surprising for us. It has been published in the Journal of Bone and Joint Surgery. That's an American journal. It's not a Swiss journal, okay? It has gone through peer review in the United States of America. Nobody quotes it. Nobody reads it. And if this has any point to being here, then it's that you should read that paper. Anyway, what does this thing say? There are two groups. There are young and active adults under 65 years. And if they have a 1-part fracture, they're conservative. If they're 2 or 3-part fractures and you can operate on them stable, then you do an open reduction internal fixation. Only if you cannot do that, you use a hemiprosthesis or maybe today a reverse. These are not the interesting group. The interesting group is the elderly patients. And there we have 2 groups. If you look on this group here, you have incompliant people which are living in a nursing home, dementia, or handicapped. All of them over 65 are treated conservatively, period. You do not, whatever it is, treated conservatively. If after 6 weeks they still have pain, they go to non-operative treatment. If they have no pain, if they have pain, they get a reverse total shoulder. Now, the other ones who are compliant, if they have good bone quality as measured by the DTA, which you can have on a conventional AP X-ray, they're treated like the young ones, exactly like the young ones. Does not matter how old they are. If they are non-displaced, and then they're 1-part, they're non-operatively treated. With the 2 and 3 parts, varus valgus impacted non-operatively, and if they are over 70 years, they are with a reverse total shoulder, and the 4-part fracture dislocations go to reverse. So it's a very standardized algorithm. It looks complicated, but is actually not very complicated. Now, the interesting thing is, I don't know whether you see what the interesting thing is on this slide. The really interesting thing on that slide is the lowest line. If you do that, you have, of about 330 patients, you have 226 which are treated conservatively. You have a small group which is treated with open reduction internal fixation, and even a smaller group with reverses. Now, the interesting thing is you have the constant score at 1 year and the subjective shoulder value. And the interesting thing is that all 3 groups, the conservatively treated, the open reduction, and the reverse, get excellent constant scores and excellent subjective shoulder values. And if you look at the quality of life before and after trauma, it is the same. Using this algorithm, you restore the quality of life pre and post-operatively. So you have the results of the Proffer study there, and you have the study with this algorithm above. So it could be shown that those surgeons who did not adhere to the algorithm, for whatever the reason was, they had inferior results if they did not adhere to them. So that's for the indication. I think that's the most important thing that I can tell you. Indication is of very, very, very big importance to have good results. Now, for the group that we are interested in, and you know that I have a possible conflict of interest with Bone Bridge, which creates implants for fracture surgery. But I also have a conflict of interest because I would like to have good treatment results. So it's a little bit difficult to see which one is more important. So the quality of surgery is certainly very important. Now, what we do in this group is we do not look at the fractures or at the results. We look at complications. We study complications and then try to extrapolate from the complications what other or different implants should do to prevent these complications. What do we know from complications of open reduction internal fixations? We have screw perforation, we have secondary varus displacement, and we have malreduction and secondary displacement of the tuberosity. Primary screw perforation into the joint is something that you can absolutely avoid with conventional X-rays in the OR. So there's no excuse for primary screw perforation into the joint. Another thing is if the humeral head collapses. Now, secondary varus displacement of the head is not rare, and I'll get back to that. And the third that we see is either mal to non-reduction of the mostly greater, but often no lesser tuberosity, or secondary displacement. So these two young surgeons who are not yet working in the office, but in the OR, they looked at these problems and designed a plate or an implant which should help to address these three problems. It's not just a new implant, it's an implant that should address the problem. Now, what was done? It was done an implant that holds the greater and the lesser tuberosity in place, and it uses screws that are mostly coming from anteroposterior and posterior-anterior rather than going straight into the joint. Now, what are the specifics that were looked at? First, to look at the problem of secondary varus displacement, a metadiaphyseal valgus was constructed, and in addition, the anatomically positioned and formed tuberosity arms. Why a metadiaphyseal valgus? In most fractures, you shorten a little bit the humerus when you do open reduction internal fixation. If you do that and you have a trumpet-shaped proximal humerus and you get shorter, you will have an overlap on the medial side. That means you will not have calcar contact anymore unless you do a little bit of valgization. So these here are standard plates. And if you reduce a fracture, that's the middle, and then you adapt the plate, you displace the humeral head medially, and you get loss of contact of the calcar, which invites secondary varus displacement. So you have loss of medial support. And if you look at these cases, that's very typical for a fracture fixation with the standard plates that you have. The calcar contact is lost, and then you have secondary displacement. So if you have this valgus that you see on the right side, then you get good contact and you get reduction of the medial calcar to stabilize and prevent inferior calcar displacement. Obviously, you also need a calcar screw, that everybody knows that. But the second thing are the tuberosity arms. The tuberosity arms are formed according to a statistical shape model, and they're anatomically formed. If you have put the plate 1.5 centimeters below the tip of the greater tuberosity, and the greater or the lesser tuberosity do not fall exactly underneath these arms, the reduction is not correct. So it's an indirect reduction aid. Now, that does not only work in Switzerland, it works well in Switzerland, but this is a case from Andy Chu from Houston, who is using this plate. And that's for us, that is a relatively difficult fracture, not an impossible fracture, but 39-year female bicycle accident, reduction. He does that with an elevator. I do not use an elevator. I use a laminar spreader so that I cannot over-reduce. I just open the laminar spreader slowly until the head is at the right height. But he did that way, and he did it well. As you see that here, then he pins it preliminarily. Pins also, it looks like the calcar screw. Then puts on the plate, fixes the plate, and the anteroposterior screws do not have to be all too long because the medial lateral and lateral medial, the anteroposterior and posterior anterior are long enough. So this is the result. 5 months post-op, patient is healed. Now this here is another case, a 3-part fracture associated with a seizure. Same thing again, reduction of the head. And that's, for us, that is for me, that it would be a difficult fracture. And that's the way these fractures are adapted. They are reduced under image intensifier, and then the plate is adapted to the tuberosities. This is the postoperative imaging or the imaging control. And you see as well in the axillary view as in the AP view that the reduction is quite good. Here the patient is at 6 weeks, fully mobile, and here at 3 months, here at 1 year, with a relatively good result. Fracture dislocations. Here, I saw a great case this morning at Grady where they did a fracture dislocation really very elegantly. I would probably have done a reverse prosthesis, but they reduced that well. And here, in a young person, we use the word bioprosthesis. That means we know that the head is going to be avascular. That head, this head here is avascular, period. It's going to be avascular, whatever you think, it's going to be avascular. So the problem is a hemiarthroplasty has also an avascular head. So, avascular, the question is, will it collapse or not? And the data says that if you have a perfect reduction of the tuberosities, then you may still have a very good result, despite the fact that the head collapses. So we call the head a bioprosthesis and leave it there. Here, this patient is 20 months post-op, relatively well reduced, I would say. And you see that the head is avascular, certainly a vascular problem that was expected. But he is 20 months post-op, and here he is 20 months post-op, still working fully as a manual worker. One of these days, the head may collapse and he may need a prosthetic replacement, but that can be an anatomical prosthetic replacement because everything was anatomically reduced. This is a 16-year-old with a scooter accident and a head split fracture. Looks easy in the beginning, but if you then look at the CT scan, it's not such a nice fracture. And this fracture was also treated with such a plate, 6 months post-op. And this is the girl at 6 months. She is smart enough to bike again. So in summary, I think current concepts of fracture treatment, to make it short in Switzerland, the bone quality is more important than the fracture classification. If you consider treatment with internal fixation or with other means. Second, I think that it is crystal clear that the results depend on the indication. And we need to use an algorithm if we want to have reproducibly good results. And the indication are probably more important than anything else. As in arthroplasty, reduction and retention of the tuberosities is crucial. Better indications can definitely improve results. And we believe, and our current data suggests, that better implants, this can also be a nail. I'm not speaking against nail, but better implants that really address the problems of the currently known complications may help to improve the results by retention of the tuberosity. And I think that's about what I could say about the current ideas about proximal fracture treatment of the humerus in Switzerland. Thank you. Yes?
Dr. Gerber, real quick question. Love the presentation. Question, what do you do with the bicep? Because the anterior plate is strangling the bicep, is what I'm thinking. And that's a source of pain in a lot of shoulders. So what do you guys do routinely with the bicep?
I would say that, since the work of Doug Harriman, I think it was sometimes in the late 90s, where he showed that you have an intra-articular fracture. You get hematoma in the joint. If you get hematoma in the joint, you usually get adhesions of the deltoid of the biceps tendon in the groove. And if you try to abduct, then it folds up because it does not slide in the groove, and you lose range of motion relatively regularly. So in intra-articular fractures, we do a biceps tenotomy. I mean, systematic biceps tenotomy, leave it in the groove. How do we do it in extra-articular fractures? In extra-articular fractures, we actually, according to the surgeon, we leave it or we cut the biceps also and do a biceps tenodesis. There was a fear that the anterior tubercular arm would create a problem underneath the coracoid, but that has not been observed so far. It's not a problem. Yes, Jared?
Are these all done through a deltopectoral approach, or are there any deltoid split? Do you think that posterior arm of the plate can be done or approached to better with a deltoid split? Will that box you out from getting to the lesser tuberosity?
No, actually, they are all those that I have showed you. They were all done through a deltopectoral approach, and actually, it is. If you think of it theoretically, you think it's going to be difficult to do that through a deltopectoral approach. But if you see here, for instance, you get to in internal rotation, you get very easily to the posterior aspect, and we use these Brown retractors, or we never take the deltoid. We never take the anterior deltoid off. There are surgeons who are using deltoid split, but they use deltoid split because they always use deltoid split. And the standard for all the fractures that I showed that we have in our country is certainly deltopectoral.
That was one of my questions, though, and I've used it a number of times, and I only do, unless it's an isolated tuberosity, and the number of these that I've done, you can really easily get it. I just save it until the end with big internal rotation.
So you have enough fixation where internally rotating is not going to displace your greater?
Yeah, exactly. I've been really happy with it.
Okay.
I have a question for you. So you've seen in your lifetime where there was a big focus on maybe 20 years ago, big focus on the CalCAR, big focus on like people like JP Warner trying to use allografts to reconstruct the metaphysis and get the head perfect out of varus, et cetera. But now with innovations like this, past couple of those, nail focusing on the tuberosities and more evidence suggesting that that's probably the most relevant aspect. One, what is your opinion on a nail like this with screws away from the head versus a plate like this with screws away from the joint versus a nail that has screws away from the joint, i.e. one of Pascal's or some of the more recent nails that have been developed? And then two, so is this going to be the key going forward? Is tuberosities or what do you see as the next sort of decade plus of innovations in proximal structure?
Well, the only thing that is certain about the future is that it is uncertain. So I don't know what the future will hold. The way I think and the way I work is I try to identify complications, failures, analyze these failures, and try to address these failures. That's the way I go for it. Now, I do not think that there is one way to address failures. There are certainly several ways that you can address failures, and one certainly is the nail. Now, in Switzerland, the nail for the humerus has a very bad reputation because it was used for essentially also shaft fractures, where it really did not work well. So it has historically not a very good reputation. Then the second thing is that we think that very many of these persons will ultimately, for one reason or another, may need an implant removal. If you need to remove a nail which has been introduced through the head, that's relatively difficult to do without really injuring the cuff. That's difficult to do. You know, it's true that with some very straight nails that go through the middle of the head, not through the tendon, that you can avoid the tendon, like Pascal Boileau's system. But removing it is a little bit a different idea. And we are, you know, I would rather have an infection with a plate than with a nail. I would rather have to take away a plate than a nail. And it's a school. You know, I said this morning, Maurice Mueller was my first teacher. And when we were young residents, the professor would ask us, what is the orthopedic question? And then we would think, what is the orthopedic questions? Are you all right? Or what is wrong with you, you know? And then he would repeat and say, what is the orthopedic question? And then he would ultimately say, remember that I told you that the orthopedic question is, what next? What next? Because whatever you do, it will occasionally fail. And make sure that you know what your next step is. And I prefer to have to take, if I have a non-union, I prefer to do it with a plate than if I have a nail. But I mean, if somebody is very, you know, very versatile, very, very good at nailing, maybe it is as good. It's, you know, the question is not whether you use implant A or B. The question is whether you intellectually approach these fractures correctly and try to prevent the complications that are possible. And then you'll have to find out whether it works or not. And I mean, in Europe, they say there are many ways that lead to Rome. You know? Actually, all lead to Rome. That's not true in orthopedics.
One last question on this. So we just did a study looking at the incidence in the United States of proximal humerus treatment over the last decade. Basically, open reduction internal fixation has stayed pretty much constant. Non-operative treatment has basically stayed constant, maybe dropped a little bit. Reverses have just taken over. Now there's, I think it's, I can't remember the exact data, but I think it's like 7 to 8 times the number of reverses being put in for proximal humerus fractures than open reduction internal fixation in the US. So there's clearly this reversomania when it comes to treating these as a sort of end-all be-all, especially for older patients. Do you see that trend continuing to happen? Is this a United States phenomenon? Is this something that's going to swing back into the middle and have some sort of regular standby? Like, why? I guess, what's your thoughts on that, and what's your thoughts on, is that going to continue in the future?
Okay, I think I have some conventional and some unconventional thoughts about that. The conventional thoughts are, it is unquestionably so that reverse total shoulders is easier than a difficult open reduction internal fixation. It's much easier, you know, and you can do it with, you know, reasonably good. It's also a relatively forgiving operation. So it's easier. It's easy, relatively easy to do. Open reduction internal fixation is, I think, is a more demanding procedure. It's actually the same thing as with anatomical total shoulders and reverse. You know, anatomical are much more difficult to do than reverse. That's one of the reasons why they go up that much. That's one thing. So we observe that too. Now, the unconventional thinking, I think, is very important. It is so that when I was younger, there was a company that was called Synthes. Okay, the company called Synthes, they produced plates for open reduction internal fixation. Period, paragraph. Okay, and then there were other companies like Zimmer Biomet. They were producing prostheses. Okay. In 2025, Stryker produces plates and prostheses. Zimmer produces plates and prostheses. DePuy Synthes, or J&J, produces plates and prostheses. If you have a proximal humeral fracture, Stryker will either sell you a plate for $1,000 or a reverse total shoulder for $12,000. So what are they going to push? I have no idea what they could push, but I could imagine that all the speakers who speak about fractures, who are working, who have developed this and this and this and this, may be slightly biased. I mean, they may not be, but it theoretically it could be, you know. And if you see how companies push reverse total shoulders, and if you see what kind of fractures are treated with reverse total shoulders, I do not think that that is a biological rationale. So
do you think it's going to continue though, or do you think we're going to step back and get better and better implants for?
Well, you know, pendulums swing always back. That's even the tariffs will go down in Switzerland. So, but overall, I really think that there are also a lot of surgeons who like to be challenged, who like to do something that is really good. And there is one thing that, you know, I've been an orthopedic surgeon more so than a trauma surgeon in the later part of my career. But I must tell you, there's a fundamental difference. You know, orthopedics treats, good trauma care cures. Okay, if you have a tibia fracture and you're well treated, you're cured. Period. You're cured to the end of your life. If you have a total knee replacement, you're treated. Okay, and you're going to be treated again and again and again. So if you have people who can cure you, you probably prefer to be cured than to be treated. That's different if you have, if you're internal medicine. If you look at our pharmacy, our pharmacological companies, they do not want to cure you. I mean, you should inject Ozempic every day, you know, every day. They don't want a drug which cures you and it's done. I mean, where would you make the money? So, you know, as a patient, I love two things. And as a researcher, I love two things. I love prevention and I love cure. Okay, that is our other thing. And if you look at orthopedic surgery, I mean, what were the really disruptive progresses? I mean, it was Salk. You know, it was Salk, poliomyelitis vaccine. I mean, before Salk, we had conferences for weeks, which tendon transfer is the best for these poliomyelitis children. And then a guy comes and says, it's gone. Okay, look at rheumatoid arthritis. When I was young, we did a lot of rheumatoid surgery. Didn't some guys come and said, it's gone? And one of these days, somebody will come and say, osteoarthritis, what was that? You know, when I was born in the hospital that I was responsible for 22 years, when I was born, they treated three conditions. They treated poliomyelitis, they treated clubfoot, and tuberculosis. These were the three orthopedic conditions in that hospital. Over. So if you ask me about the future, I don't know what it will bring, but it will be different than what we think now. Okay. Do you want to continue with the posterior instability, or shall we stop?
Yeah, I guess I'll continue.
Do you want a bottle of water or anything?
Oh, no, I'm fine. Let me quickly see.
Yes.
Thank you, sir.
Thank you. That's very kind.
Perfect.
Let me just take one thing down here. I just want to move one side. I just want to move this slide to here. So that's good. We can start. Okay, we can start.
You're good. You need a break or you're good?
No. I don't need a break. No, I'm fine. I'm fine.
Talk.
I'm fine. Okay.
All right, guys, we're gonna continue the second one. And then we'll open the floor to questions on both this talk as well as anything else that I want
Yeah, getting reverse.
Well, this second talk is a little bit a talk which documents how stupid I was or I am over decades. And we are going to talk about recurrent, or we're going to talk about posterior shoulder instability and about two forms. I'm not going to speak about the locked posterior dislocation. I'm just going to talk about two things. The first one is this strange static posterior subluxation, which occurs almost without symptoms often. Patients are painful, really do not have a lot of symptoms. They have pain, they develop osteoarthritis, and the head is just a little bit too posterior. And the second one is the mostly positional instabilities of these persons who elevate their arm, the head pops out the back, or they have had trauma and they can reduce it and goes back and in. So it's recurrent posterior subluxation, so to speak. Now, what we do know is that this posterior escape that will be important for the case that I want to make. This posterior escape, called glenoid B1 or B0, progresses invariably to B2. We know that if you have that, we know that it will result in a B2 and in osteoarthritis. I think that is relatively uncontested. That's for the static ones. Now, for the dynamic ones, that's quite interesting. Dynamic posterior instability, people think it is a labral lesion. Well, posterior banker does not work. 36% recurrence rate in some studies. Others say they all have capsular redundancy. Well, posterior inferior capsular shift does not work in the long run. 20% or 25% recurrence rate. It is glenoid retroversion. We correct glenoid retroversion. These are two papers of our group. That does not work. You need to do a posterior bone block because it's too small. Does not work either. Now, muscle coordination, well, the pacemaker improves some patients, but never cures them, never really cures them. Now I have a slide for the residents. Look at that slide very precisely. What do you see on that slide?
A slide.
Huh? What do you see on that slide? Look at it close. What do you see? Huh?
Black dot.
Black dot. Anything else? Okay. Black dot. Good. Very good. Oh, very good. Now, this is another slide. What do you see here? Huh? Anything special? Just a tree, huh? See anything more? Okay. Tree, huh? Do we agree? Tree. Okay. Okay, what you see here is 99% of white stuff. Okay? And the point that you see is looking or not seeing the forest for the trees. Okay? The big thing is that there is 99% white stuff that you can write on. Now, this one here is a really interesting one. You really have to look at it well, because if you look at this here, there is a branch that goes to the ground. And it is a support for this branch. This branch would break if this tree had not created this support. What I want to tell you is we are very good at looking, but not good at seeing. We look at things and don't see what is there. We don't see what is there, although it is there. And that is the history of posterior shoulder instability. Okay. This is that is the case that changed all my view of what I'm talking about now. This is a patient in whom I had to do a posterior Bankert. Okay, you see it's a somewhat redundant capsule, easy access. Well, the bad thing about this slide on the left was I had 3 visitors who were standing in the OR. And I was doing the arthroscopy, very elegantly showing you how to do that, like elegant, Then I do that, I put the scope in, and I'm in the subacromial space. So I was a little bit embarrassed, so oh my God, So I take it out, I put the scope in again. I'm again in the subacromial space. And then I said, well, I've done a few hundred scopes, I probably should be able to find the joint. And then I looked at the X-ray and saw that if I start here, I have to introduce the scope like this to get into the joint. And if I start from here and I insert the scope a little bit like that, I will be in the subacromial space. So I call my best collaborator, Dominic Meyer, and tell him, Dominic, do you see something? This is posterior instability and I don't find the joint. He looks at me and says, uh-huh. And you think that posterior acromion is important, huh? I said, yes, it may be. I don't know. It may be. But then we started looking at this acromion, and what we found was that the left side is a posterior instability and the right side is an anterior instability. And then we thought, well, is that a case? Or are these cases, or is it a series? And the fact is, it is a series. And the interesting thing was that we asked ourselves, well, what does that mean? And we thought we should think about that. Well, I mean, that's not normal. It's not normal that they are so different. We have never realized on near views that they are so different. We had looked at these near views without seeing anything. So we looked at the posterior acromial morphology and found that it was very significantly associated with posterior shoulder instability. What we measured was what we see here, the posterior acromial tilt. So how much is the acromial tilted? Then we measured the posterior acromial height. How much above the center of the joint is the posterior angle of the acromion? And we measured the covering angle. How well is the head covered posteriorly? And we saw that these were huge differences between normal shoulders and anterior instabilities and posterior instabilities. And if you had a posterior acromial height which was higher than 23 millimeters, the odds ratio for posterior instability in these shoulders was 32. So, well, it was relatively clear that posterior acromial coverage was the same thing. There was a 61 degrees angle for the normal ones and 49 for the other ones. So, well, what does that mean? We said, well, that's two-dimensional and maybe methodologically not so good. So we'll have to look at that in 3 dimensions, and we segmented a large number of shoulders, 40 controls that were definitely normal, 30 dynamics and 20 static that were not yet arthritic. Well, we found what we had expected, that the instabilities are a little bit more retroverted. What we had not known was that the posterior instabilities are also inclined. They're not only retroverted, they're also inferiorly inclined. I had not known that before, but it was very significant. But then we looked at the acromion, and we looked at the acromion, and these acromia in these instabilities were very interesting. They were clearly different from controls, but they were very similar between dynamic, so the posterior escape, and the static ones, except for the critical shoulder angle, which in those that are static is even smaller. So they have a shorter acromion. But you see that the posterior height and posterior coverage is really 8 or 10 degrees less posterior coverage. And that was just always like that. Now, if I said in the beginning, B0, B1 goes over into B2 and the eccentric osteoarthritis, okay? If I say B0 goes, and then I say B0 is caused by a high acromion, there's no other way that osteoarthritic shoulders, which are eccentric, must also have a high acromion, okay? And that's the case. If you have a concentric osteoarthritis, then the shape of the acromion is normal. Left side, that's a type A, and B is a type B. So it is true that these cases evolve and go into osteoarthritis. Not the same patients, but X years later, they develop the same thing. So the typical acromion in static posterior instability is identical to the acromion in the elderly patient who has eccentric osteoarthritis. Why is that? Because if you elevate the arm, the head can flee, I think you could say, underneath the acromial roof. To study that better, we created a mean statistical shape model of these 40 normal shoulders and defined what a normal shoulder really looks like. And then we tested these normal shoulders against a typical case of a posterior instability as segmented. And you see that here. If you load these, you see how on the left side, normal statistical, mean statistical shape model, you never get, you abut against the acromion. Here we are at 60 degrees of flexion, but on the right side, with a pathological acromion, you subluxate posteriorly. Now, that was a 3D model, and we thought, well, the community will not accept that as a proof. They think, oh, that's Swiss technology again, 3D printing. So what we did is we looked at the acromion and posterior instability in normal glenoids. So we took 8 specimens. That's going to be published very soon. Actually, it's in print, Journal of Shoulder and Elbow. And we took a normal one, normal acromion, and then with the jigs that we used to correct, we created a normal acromia and the types of acromia that we had identified as being typical for posterior instability. You see here, we use cutting jigs, and then we can fix that exactly in the position that we want. And what we got was this here. You see that the overcorrected green is you have a force displacement curve, and you just see that the severe malalignments in dark red, they need a lot less force for posterior displacement and displace a lot further. Now, even that, which is relatively good biomechanical data, is probably not enough. So what we did is we did a study in Sydney with a shoulder, with an animated shoulder model, with a simulator. And the simulator showed that if you have only the glenoid, you have already a substantially more displaced posterior displacement. And what we could show here is that you cannot correct that by only correcting the glenoid. You cannot. But interestingly, you can also not correct it with correcting the acromion only. You have to correct and to restore a normal balance between these two items, between the glenoid and the acromion. So this was all biomechanical studies. And then my fellow Bettina, she was working in Melbourne, and she reviewed a large series, 73 cases of posterior bankards, and looked at the recurrence. And she did that with MRIs, measured posterior acromial height, measured posterior acromial coverage. And the fact was that the odds ratio, if you had a posterior acromion coverage which was smaller than 61 degrees, was infinite. Now the chances, I mean, it was sure that they would redislocate, whereas those who had a normal acromion did not. So then we said, well, if that is true, what we are believing, what we're saying, we should be able to correct these conditions. And what we did is we looked at such a case. This is such a case with that is a static patient. You see here that he has 40 years old. He has a little bit limited internal rotation on the left side. He's almost normal range of motion, but is somewhat painful. You see here that he has mild osteoarthritis, has overloaded posterior aspect of the joint. And what we can do is, using the statistical shape model, we can correct exactly the acromion and the glenoid to the statistical shape model. You see here in blue, the original part. Green is always the normal anatomy. So on the right side, that's postoperative acromion. We did that surgically. We elevated a little bit the glenoid and we corrected the acromion. That is about what it looks like after 4 years. So after 4 years, the patient is perfectly centered. His subjective shoulder value is 100%. Now, if we looked at the first 8 cases with static posterior subluxation 2 years after the operation, we could, in 6 cases, we could completely recenter the joint after 2 years. And in 2, we could improve it, but not completely normalize it. So we think that's a fairly reasonable proof of concept of restoring normal anatomy. Now here we are with the dynamic instabilities. And if you have an anterior instability, look at the near view. And if you have an anterior instability and you have this acromion that you see, you may have a posterior instability. So this patient had been operated for an anterior instability, was always unstable posteriorly. That was his preoperative shoulder value was 20%, constant score 54%, very painful. And now I show you how you can analyze the deformity. Here we need a graft for 4 millimeters to correct the glenoid, and we need a correction of the acromion. And what is quite important, especially if you do a correction, you have to lateralize the acromion. You have to bring it down posteriorly, and you have to lateralize it, because if not, the critical shoulder angle becomes too small, and you develop, or you favor the development of osteoarthritis. We then can make these custom-made jigs to exactly, you cannot do that by eye. It's not doable. You have to really measure exactly the wedge that you have to remove, correct it, and then you have a reduction guide that you see here. And usually you can fix the acromion then in the predetermined position with just 2 screws, as we do it here. You see how much it has been lateralized. You see how much it has been brought down from the blue to the green situation. That is the osteotomy effect, that you can see how you bring the head forward, how you bring the head laterally. And I don't know, same thing on the lateral side. First, you bring it forward, the head with the glenoid, and then you cover the head posteriorly so that it cannot escape posteriorly. Now, this is such a case, pre-op, that's this case, preoperatively and postoperatively. Here he is pre-op. Here he's post-op, 18-month follow-up, and that is his function. He's fully stable and goes back to work after 3 previous operations. This is another patient, dynamic and stable, with early, actually quite interesting osteoarthritis. As you see it here, I think that is, I mean, I think for most persons would agree that this is static subluxation, that this is not a center joint. those who are have the habit to look at the acromion probably see that this is not a normal acromion. So that is pre-op and 2 years after surgery in a patient who had already osteoarthritis. And here he is not free of osteoarthritis, but he is much better centered, and he's doing quite well for a patient who has had this type of pathology. So currently we are at 2 years for a little bit more for 8 patients. Subjective shoulder values are all patients that were really not doing well. 6 of them were operated previously. They go from 30 to 80, constant score to 80. They are all but one are stable. In one, I completely failed with the correction. This is a failure. This is one failure where, the position of the acromion is like preoperatively, just a technical failure. But the others are doing quite well. So I really think that if you don't mind, I will tell you a little funny story. You are an orthopedic surgeon doing trauma, okay? Actually, let me say, we were looking at the glenoid all the time, okay? We were glenoid A, glenoid B, glenoid B1, B2. You're an orthopedic surgeon, you're on call. You're doing a case at night. You want to go home, 2 o'clock in the morning, 2 o'clock in the morning. You want to go home, you take your scrubs off, you look at pants, and then you want to leave the locker room, and then you realize that you don't have your wedding ring. Bad news, okay? You don't go home at 2 o'clock in the morning without your wedding ring. So what do? You go back to your scrubs. You look at the scrubs, you don't find it in your scrubs. Maybe these were not your scrubs. So you look in the other scrub, you do not find it. So what do? You go with the whole bag, you go to X-ray. You do not find the ring. What is the conclusion? The conclusion is the ring is not there. Okay? The ring is not there. And if you look for 15 years in the deformity of the glenoid and you don't find the answer is not there. Okay, so that's why we came to the acromion. And I think scapular corrective osteotomies can restore posterior stability, and so far relatively reliable, the first cases. And we are not sure, but safe answers will never change the world. Thank you very much. I do not expect anybody to agree. Have any questions or comments or?
So to give you all a background on this, so Professor Gerber was one of the original people to describe and then perform glenoid osteotomies. He was the one who most people would quote on how to do it. Initially started with a wedge and eventually this sort of J type of graft that was done forever. And so, interesting enough, he was the one who probably taught the world how to do glenoid osteotomies, or at least one of them. He was also the one who sort of condemned them. So his long-term study was, I think, the sort of nail in the coffin on why very few shoulder surgeons anymore do glenoid osteotomies, or at least if we do it with a lot of trepidation because of his long-term study. So a really incredible example of somebody who saw a problem, got a fix, had a fixation that early term seemed promising. The world sort of followed suit, or at least in some respect. I'm sure not that many people were doing that. And then he sort of like looked at his results and said, no, actually this doesn't work. And still to this day has the longest term study on this. And truthfully is like the reason why personally I don't believe in it. So he's obviously has a different way of looking at this, but there's a really classic example. If you think about this, I don't know, I can't remember when your first paper on glenoid osteotomy was Professor Gerber, but I want to say it was like 30 years ago.
Yeah, probably 30. Yeah, I'm a little bit ashamed, but I think it was 30 years ago.
And crazy to see this revolution, but it's also maybe for the young surgeons, see what changes. And and you can be part of this change, especially if you are talented and thoughtful about this stuff. So it's incredible to see. But without that background, I don't know if y'all can appreciate this this new way of thinking. This is one of the hardest problems in shoulder surgery: is static posterior subluxation. And these young patients that show up, and shoulder replacements, we do them because people get statically subluxed. Eventually, they get arthritis, and then eventually we do, augmented total shoulders or reverses or whatever on them. It's a hard problem. Nobody really has an answer. It's cool that very innovative people are trying to continue to answer this problem.
Maybe it's not the answer, but we've tried. And the thing that I would really like to convey to the residents, I made my career by proving that what I was taught was not right. That was essentially the basis of my career. And Dominic Meyer, who I quoted here, who did a lot of the work together with me, who unfortunately died very early, he taught me one thing that I think is of incredible importance. He told me, Christian, the fact that you know something does not mean that it is true. That's very, very important. We were very often in conferences or so, people say current knowledge, it's according to current knowledge. It is not current knowledge. It is our current illusion of knowledge. It's not knowledge. We knew that Earth is a disk. We knew that all rotator cuff tears are caused by subacromial impingement. We knew that. It was just never true. So I think it is. It's very important that the resident listens. But the only teacher who I accept, the only one, is my patient. The patients tell you the truth. I mean, the textbooks, they are 85% copy paste. They're not. That's not true. And if you find something in the textbooks that you cannot reproduce in your patients, the patient is right, not the textbook. So and that gives you, if you compare your patients to what is in the textbooks, I guarantee you that you have enough questions to answer to the end of your life. Yes, Jaimo?
As you know, I'm a trauma surgeon, not a shoulder surgeon, so I'm coming from a point of ignorance. So I'm thinking of the humeral head sitting on the glenoid, it's subluxated, and it's statically subluxated. And then I'm thinking about the acromion, which is a static structure that doesn't normally, in a static setting, articulate with the humeral head. And then you're taking that static structure and you're moving it into a position where it still doesn't articulate with the humeral head. So to me, that makes me think that what you're really doing is changing the dynamics of the shoulder and pushing it. You're not statically changing, you're dynamic. So is that because you're changing deltoid vectors? What do you think is actually happening to move the humeral head?
Well, the fact that your contention that it is not articulating is probably not correct. The humeral, the rotator cuff is in contact with the acromion superiorly and posteriorly. It is not in contact radiographically, but it is in contact. In arthroscopy, we are under traction and we think that there is an empty space, but if there was an empty space, we would have scar in there. There is no empty space. So if you do it in a dynamic model, in a dynamic model, then you see that the posterior superior acromion prevents posterior and superior subluxation. And you can measure the contact pressures. Now, there are contact pressures that vary. And if you have, we have measured the contact pressures. If you have an acromion that is much too high and you elevate the arm, the contact pressures between the cuff and the superior and posterior acromion are much lower than in a normal shoulder. So you have a direct contact. That's the first thing. The second thing is, I think that now I go to the Church of Shoulder Surgery, I believe, and I don't know. If you once look from superiorly on a shoulder and you correct the glenoid, just the glenoid, you see that the vector of the supraspinatus is different. It does not do this anymore. It is straight and elevates straight without pulling posteriorly. So the position of the glenoid that you also correct is certainly an element. The second thing is that if you tilt the acromion, you're right, then the vector of the deltoid changes. Now, which one of the different factors is the most important one? I do not know yet. The approach was a little bit different. The approach was, is a normal shoulder anatomically different from a statically subluxated shoulder? The answer is yes. Okay. Second question was, if we restore such a shoulder to a normal shoulder, is then the static subluxation corrected, yes or no? The answer is, so far, unless there is severe deformity of the glenoid, the answer is yes. Okay. Now, Michel de Montaigne is a French philosopher. He has said, I always see people very interested in finding out why things are so rather than to find out whether they are so. And I am only at the point where I know yes or no. I do not really know yet why exactly. I do not know why. But the fact that we can show that if you correct that you can restore normal mechanics, at least invites us to really study now in the next step why exactly, which are really the factors, which are the vectors that determine that it is so. And it is very interesting to see that a normal shoulder, a completely normal shoulder, has very little variation. It's not large standard deviations. Now, in posterior instability, it's very strange. You have patients who have quite a bit of glenoid deformity and acromial deformity, but you have others who have a completely normal glenoid and have severely abnormal acromion. And you have very few who have no abnormal acromion, but just the glenoid. And in those, you can just correct the glenoid. But it is an interplay between these two factors. That's something for Mara can do that. That's for artificial intelligence. What is really the combination of these factors to find out what are the critical things? For instance, we have now a question. We have 2 degrees of deformity of the glenoid. You really want to be correct 2 degrees of deformity? Do you really want to do that? I have no clue whether you should do that or not. So currently, we probably say we overcorrect the acromion a little bit. But is that right? We the thresholds. I don't know the thresholds, and but I'm convinced that it is all the data, how I can interpret them, are in favor of this being a combination between the deformity of the glenoid and the acromion. There may also be a factor of the humerus, which we have not properly analyzed, but I think this would be something for AI, to really say what are the critical things that must be fulfilled if you want to correct and obtain stability. That does not answer your question, but that's all I know. Yes?
So you mentioned earlier, like the soft vaccine improvement.
I don't hear you, excuse me.
Sorry. So earlier you mentioned patients, the revolutions of medicine that prevented a lot of the maladies that we don't see anymore, like polio, tuberculosis, and things like that. So when we're talking about malalignment of the shoulder, do you foresee that all this, I think of what you're talking about, I think of, hip dysplasia, I think of shoulder dysplasia almost. And do you foresee in the future that we have to diagnose these patients earlier and have any type of preventative, the equivalent of even like a tablet purchase for the shoulder to realign the patient before they become
Osteoarthritic?
Osteoarthritic, yes, sir.
Sure, that's what it was all about. But I'm a pupil of Reinhold Ganz. I mean, his lifetime was to prevent development of osteoarthritis, to treat early osteoarthritis, and prevent it from progressing to total hip replacement needed at age 30. So it is clear that that we would like to get to a point where we can prevent people from needing an operation, which is, for instance, a total shoulder replacement. I can tell you that we're going a little bit far right now. We currently think that for those who have this hyacromion, where everybody puts in reverse total shoulders, if we correct the acromion and use a wedged glenoid that restores the glenoid, we go for anatomicals because we prevent the forces that subluxate them posteriorly. So you can use it maybe for treatment, but the goal certainly would be to understand why, what was for me the most interesting question in sports medicine? The most interesting question for me as a shoulder surgeon was, why does Roger Federer not have a rotator cuff tear? Why does he not have? I mean, it's not interesting to know why people have a tear. It's interesting to know why they do not. Why does your shoulder not subluxate posteriorly? Why? And I think we should go from there. We should not go from the pathology. We should look at the healthy side and then restore the healthy side. Now, if I may extend to that, like we have always a big discussions with people in this country about anterior shoulder instability. We here the opinion is restoring glenoid tract, restoring anchored lesion or whatever. I really think that is wrong. I really think that is wrong, because these glenoids and these shoulders, when they were at the time of the first time dislocation, they all were on track. They all had a normal labrum, all of them. So why do you restore a situation that was compatible with a first time dislocation? That's stupid. So what do? We do a lateral because we increase the size of the glenoid. I mean, these are the same persons tell me nothing is better than restoring normal anatomy. In the next session, they tell me that they do reverse total shoulders. I mean, it's beyond me. I do not understand anymore. But the question is, I agree that this is a little crazy, but I think, why do certain persons, if you go to West Point, go to West Point, 20% of the cadets sustain a shoulder dislocation. It's a lot of training, a lot of risk and whatever. But why do 80% not? I mean, they do the same things. They do not dislocate. Why? I mean, these are the interesting guys, not the ones who dislocate. I'm serious, I mean, so I know that's a little bit a crazy approach, but I really think we should go for prevention, and we should, when I was a medical student, when I was in my early years of residency, it was crystal clear. It was crystal clear. There is nothing that is as good as what the Lord did. Okay. Nobody was discussing that. I was absolutely axiomatic. Do you know who was the first person who really disputed that and refused that. Do you know who that was? That was John Insel. Insel replaced the posterior cruciate with a mechanical device and said, you don't need a posterior cruciate. I mean, you do a total joint, you don't need a posterior cruciate. And then Gramont came and said, you've just got to take things reverse. And I mean, most of us agree that that's probably better than doing a hemiarthroplasty in somebody who has a cuff tear. So it may not be true that restoring anatomy is always the right thing to do. To go back to the banker, I had a patient, his name was Ernest Good. Ernest Good, I will always remember. He had had a Bankert operation and he had recurred. So he came to me and said, I have a recurrence after this shoulder stabilization. What are you going to do? And then I said, I looked at it and said, you have minimal bone loss, but I would do a latarjet. That's the thing that works the best in my hands. It is proven, blah, 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 blah. And then he says, well, I'm very happy you say that. I said, why? He said, well, he was with two guys and they said they would redo a Bankert. I said, well, I wouldn't do that. I think, if you have failed with the Bankert, I'm not willing to do a Bankert. And then he tells me, sir, I am responsible for the nuclear plant in Gösgen, that's in a Swiss city. I am responsible for security of that nuclear plant. If this nuclear plant blows up for any reason, and I tell the community that I'm going to do the same thing as it was before, I go to jail. Okay? So since then, I do not repeat, I go with Einstein. Doing insanity consists of doing twice the same thing and expecting a different result. That's enough philosophy, I guess. Okay. Yes?
You mentioned that you built your career on going against everything that you were taught.
No, that's not what I said.
Going against a lot of what you were taught. For those of us who are in training, who are very fast approaching practice, can you talk a little bit about kind of the thought process and I guess also the physical process too of taking a new idea that you think will work for a patient, but hasn't really been established, published, talked about yet, and how you take that from idea to implementing it in the operating room? Are you getting comfortable with it just in a cadaver lab first? Are you teaming up with people and discussing it? I guess, what is your kind of I know it's a very broad question, but how do you go about that?
Well, I will try to answer what my approach was to this problem. Everything starts with an observation. Medicine, I mean, the real art in medicine is observation. I mean, and then if you have observed, the interesting things are abnormalities, small abnormalities. But you find something that is abnormal that you do not find in other patients. And then you sort of try to find out whether other patients have this same abnormality and which other patients have this abnormality. And if you find an abnormality that you find interesting, like if you have a patient who is called Robert Bonestraw, who comes to you after being operated for an open Bankert, and he tells you, Dr. Gerber, my left shoulder is perfect, but with the right one, I cannot get to back here anymore. Then you say, well, you're 6 weeks and that's normal and just wait. And then he says, no, I could do that here. I cannot do that here. I cannot get here. Then you say, well, we can get an ultrasound, and the ultrasound says, well, it's difficult to say, it's a little bit swollen and all this, what have you. And then the patient tells you, this shoulder is not okay, and I want you to revise it, okay? The guy's a physical therapist and works for you. And you go to the operating room and you see an avulsion of the subscapularis. That's the discovery of the liftoff test. Okay, Robert Bonestra was the name of the patient. He showed me what happens if you have a subscap pulled off. So then you see, okay, is that typical for that? And then you look for that. You look in every single patient, you look whether this is present or not. And then you find out that it is present in this and this and this and this. Then you start doing studies in imaging or what have you. And then when you know that you have a consistent finding, then you look whether this finding is absent in other diagnoses, like, I don't know, calcific tendinitis or osteoarthritis or what have you. And then you go to the lab. And if in the lab you can prove that this makes sense, then you go back to clinic. So my approach very clearly is bedside, bench, bedside. And what I really regret, I must say, and if I see in my environment, I regret that very many young orthopedic surgeons are more interested in imaging studies than in patients. And the persons who know what they have are the patients. It's not the radiologist. The problem is that the patients cannot tell it to you in medical terms. But they know what they have. They have very clear symptoms. They have findings. They can tell you, if you listen to them, what they have. What can they not do? What can they do? Under what conditions can they? That's reproducible. They can tell you what they can do. And then you just look for whether this is consistent, and then you can verify in the literature. And if the literature disagrees with your findings, then your findings are correct. And then you go from there. So the key issue is the key issue for contributing is being interested in the patient and in observation, very precise observation, physical examination, finding out what they can do, what they cannot do, and then trying to reproduce that in certain cohorts. I think that's, and then in terms of getting things published, my paper just got turned down, okay, for scapular osteoarthritis. But I can tell you that latissimus dorsi transfer got turned down. When I submitted isolated subscapulary stairs to JBJS, the answer was, this is an interesting paper, but probably a Swiss disease. We don't have that in the United States. So it was turned down. Now this is turned down. So I go with Churchill, if you go through hell, keep going. That's if you deviate from mainstream, you will incur resistance. That's natural, because the status quo is the strongest magnet in the world. Okay, so if you want to question status quo, you're in bad shape. But that doesn't matter. And if you are 170 years old, it doesn't matter anymore whether people like you or okay.
Do you have an anterior corollary to the posterior static translation? Are you doing any osteotomies?
No, but I mean, do you know what the TRIA operation is? Who of you knows what the TRIA operation is? Okay, many do not know what the TRIA operation is. There were two chairs in the Department of Orthopedics at Lyon. One was Michel Latarjet. He made Latarjet procedure, and TRIA, the knee surgeon, made another operation. He took the acromion, he took the coracoid and osteotomized the acromion, put the nail in it, and just tilted it down, put the nail in it, did not do anything in the joint, and very often stabilized the shoulder. Now, if you look really carefully at all your anterior shoulder dislocations. I mean, just look at it. I have no proof of what I'm saying, but it is really striking how high the coracoid is in these cases. It's striking how high the coracoid is. It is not where the coracoid normally is in anterior shoulder instabilities. And it's very interesting. You know that occasionally we have a coracoid fracture in an anterior instability. That's those who had a coracoid at the right place. Now, if you have a coracoid that fractures, okay, if you have a coracoid that fractures, that means a lot of strength, a lot of force was acting on that coracoid for the shoulder dislocation to occur. Now, if that coracoid is higher up, I mean, it dislocates unless the force is so big to fracture it. So, I mean, I can tell you, wherever you look, whenever I am at conferences, they show me. They always show these CT scans from the front, you know, from the side, the near view of the CT scans. They always talk about glenoid bone loss. And every time I look at them and think, I mean, do they not see how high the coracoid is? But I think that the coracoid may play a role. I also think that the coracoid may play a role in dislocation of reverse total shoulders. But I may be wrong. You know? If I'm wrong, that's fine, but at least I look. You do not need to be right. You can at least look.
Thank you so much, Professor Gerber, for your talks. I had a more general question. You talked about all these incredible people that you've worked with, and Meyer and Fu and Patel over your career. As the chair of the department, what have you done to inspire these people, and then also, you know, inspire talent, retain people, and keep people loyal? And what have you done differently to build your department over your career?
Well, that's different. You know, you're difficult because you cannot go against your nature. You have to work where I know. You can ask my son. You know, I'm sometimes difficult. The only thing that is comfort is I am 24 hours around myself. So you are the way you are. I think it is very important that you're authentic, that you are who you are. Now, one thing that I really, you know, I do not believe in the transmission of knowledge. I said today that I think there is only illusion of knowledge. Knowledge changes every 2 years. However, I really believe in the transmission of curiosity and of enthusiasm. And curiosity is the basis of progress. You know, I mean, if you are not a curious guy, if you can sleep, if you do not understand something in a patient, you'll not make progress. I mean, if you have a patient and you do not know what to do, and you do not find what to do, and you fall asleep without thinking of that, you're probably not going to make progress. So curiosity is a key element. And I also think, you know, I don't know whether you realize that, but I have always loved what I was doing. I really like what I'm doing. I mean, we have the best profession in the world. And there's no other profession that I would ever consider. Never, ever. I mean, you know, we have, whatever we do, you know, if you're an oncologist, I mean, you're suffering. If you're an endocrinologist, you know, your patients gets blind 2 years later than if you were not there. But if you're an orthopedic surgeon, you know, they have had 10 years of pain, then they come to you and they go home and they have no pain anymore, have a new life. So you have the best profession that there is. So I'm enthusiastic about what I'm doing. And I try to sort of convince people that if we're doing well, that's what we can do. That's certainly one thing, curiosity, enthusiasm. The second thing that I think is very important is that if you want to keep the very good people, I think you have to give them credit for what they do and possibly for what they could be doing in the future. You know, if you look at the publications of, for instance, this acromial stuff, I'm almost never a first author. I mean, those who were around me, they knew that these were my ideas, and they had to do that. They had to do the studies. They had to follow up, but they did. You know, they did. If I look at Bettina Hochreiter, I mean, she did the work on. I designed the experiments, but she did them. So she deserves to be first author. She deserves, and she should be first author, because if she is first author, she's going to be acknowledged to have contributed substantially, and she's motivated to continue, because when I'm gone, somebody has to continue. And if I, you know, if I take all the, I mean, if you're a good chair, you're ready to take the blame and ready to give the credit. I think that's probably an important thing. So, and I think you should have standards. I think it is very important that you have standards, and whoever it is, whether it is your vice chair or it is the youngest president or it's the cleaning woman, that's the threshold under which we are not willing to go, whatever happens. And that is mostly centered on patient care. You know, if you're not adhering to setting top priority patients, then I think our whole profession is lost. But it's relatively important to sort of do it every day and try to make sure that you're adhering to your own principles. But you know, try to be very curious. Try to be innovative, and to give room to others. But I have had people who wanted to come and work in my department because of Dominic Meyer, or who wanted to come because of the spine guy, and not because of me. You know, they came despite me. But the thing was, first class attracts first class. Second class attracts third class. So you better make sure that, at least in the beginning, you attract first class. And you must know that your collaborators teach you a lot more than you teach them. That's invariably true. So you just got to realize that. And then they realize that you're willing to learn from them. And then it's a good collaboration. And if I look at like somebody like Dominic Meyer, Clement Werner, very, very, very talented people, the difference between them and me was age, was all. It's just age. I was just older. But if not, we were pretty much the same. And they must feel that. They accept easily that you are older as the chair.
Okay. Well, thank you very much for this. Do you think the residents want to get a picture before you leave? And then we can sort of, really, really thank you. This was very unique and social for us.
Thank you very much, everybody. Thank you.